So let's start with the anatomy of the eyelids. What is the eyelid? So the eyelid is the outer layer or outer appendage of the eye that is mainly its main function is to protect the eye. This thin sheet is, although it is very thin and very delicate, however, it is very complex because it consists of different structures like skin, muscles, fibrous tissue, and the mucous membrane in a unique arrangement, as we will see later. The functions of the eyelid is, as I told you, it is for protection. So it is the same function like the skin to the body. The eye to the eye, the eyeball is like skin to the body. So it serves for protection from the external irritation. Other functions as well will be to limit the amount of light entering the eye and to act as distributing the tears over the surface of the globe. So let's have an idea about the gross anatomy or the gross picture of the eyelids. So we have basically, as you know, we have two eyelids. We have the upper eyelid and the lower eyelid. Every one of them has its boundary. So the upper eyelid is bounded above by the eyebrow. So the eyebrow will make the limit of the eyelid. However, the lower lid is not limited by another eyebrow, but it is merged directly with the cheek. So there is no prominent distinction between the lower eyelid and the cheek. The upper eyelid normally covers the upper 1/5 of the upper cornea, so it usually covers about 1 to 2 millimeters of the upper cornea. And this anatomical configuration is important because if it is disturbed, or for example, if the lid there is a scleral show above the limbus, then this means that the patient has lid retraction. On the other hand, if the lid is covering more than 1 to 2 millimeters of the upper cornea, then this means that the patient has ptosis. While the lower lid is just resting on the limbus. So this is the normal anatomy of the lower eyelid, to be just resting on the limbus. If there is excessive scleral show below the inferior limbus, again, this will mean that we have lower lid retraction. When both eyes close, both of the eyelids will meet at the inferior part of the cornea during blinking, as you can see here. Let's have further insight into the eyelids and its boundaries. So this is the superior eyelid and this is the inferior eyelid. You can see that the superior eyelid, there is a line or a sulcus. This is called the lid crease. So it is present in the upper eyelid and in the lower eyelid. So there will be a skin crease or a lid crease that is called furrow or horizontal furrow that will divide the lid into two parts. Tarsal part, which is in front of the tarsus, and the orbital part, which is the part above or below the tarsus. So in the upper eyelid, will be the part above the tarsus, and in the lower lid, it will be the part below the tarsus. The upper lid crease or the upper furrow is very prominent and it is formed by the skin insertion of levator aponeurosis. So you remember from yesterday, we said that the levator aponeurosis has 5 attachments or 5 insertions. One of them is attachment to the skin of the upper eyelid, which will form the skin crease. While the attachment of the lower the lower furrow, the lower furrow is less prominent than the upper one, and it is formed by fascial expansion of the orbicularis oculi. So you can see that it is poorly defined and not very well defined like the superior one. The opening of the palpebral fissure or the opening between both eyelids are called the palpebral fissure. So what are the dimensions of this palpebral fissure? The width of the palpebral fissure, it's about 30 millimeters, while the height is 12 millimeters. The junction between both of them at laterally will form the lateral canthus, which is an angle of 60 degrees, while the The junction between the upper and lower eyelid at the medial end will form the medial canthus, which is more rounded. Sometimes at the area of the medial canthus, we can see a vertical skin fold covering the medial canthus, which is called the epicanthus. So this epicanthus is sometimes usually present in the children or orientals. The epicanthus, the clinical significance of epicanthus that sometimes it can give the appearance of pseudo-esotropia or appearance of inward deviation of both eyes toward the nose. This is not a true deviation. It is just a false impression of a deviation or a pseudo-deviation caused by this vertical skin fold covering the medial canthus. The relative position of medial canthus and the lateral canthus together is different according to the race, meaning that in the blacks and whites. Yes, Dr. Amr, we started. Can you see the presentation? Dr. Amr, can you hear me? Okay, so I guess he is not around. So as we were just talking, the blacks and whites, we have the relative location of lateral canthus to medial canthus is different according to the race, meaning that in the blacks and whites, the lateral canthus is 2 millimeter higher than the medial canthus. Conversely, and also the fissure is widest between the junction of inner 1/3 to and the lateral 2/3. This relative positions are different in orientals. So in orientals, the lateral canthus is usually higher than medial canthus by about 5 millimeters or even more. And the palpebral fissure height is equally on both sides from the center. So the widest area of the palpebral fissure height in orientals will be at the center. And usually the epicanthus is normally present. So as we said, or as we discussed in the orbit, we started the discussion of the orbit by mentioning the anatomy of the orbital margin. So here we will start the anatomy of the eyelid by the lid margin. So the lid margin is about 2 millimeters thick and 30 millimeters wide, and it consists of two parts. These two parts are divided by an eminence or an elevated area at the medial part of the eyelid margin. It's called the lacrimal papilla. So the lacrimal papilla, it is a small eminence about 5 millimeters from the medial angle that contains the punctum that is responsible for drainage of the tears. This punctum or this lacrimal papilla will divide the eyelid margin into two parts. Lateral part, which will contain the eyelashes, and the medial part will contain the lacrimal canaliculi. So we have the lacrimal portion and the ciliary portion. Ciliary portion, which will carry the eyelashes. Lacrimal portion, which will be devoid of the eyelashes and carry the lacrimal canaliculi. So what will be the difference between the ciliary portion and lacrimal portion? Ciliary portion, it is the lateral 5/6 of the eyelid margin. It has a sharp edge to allow free movement of the tear film until it is drained by the puncti, and it has certain anatomical structures like gray line, white line, and eyelashes. These structures are not present in the lacrimal portion, so the lacrimal portion doesn't have any eyelashes, doesn't have any lines or gray line or white line. There is no tarsus, and there is no glans opening. Let's discuss further the ciliary portion and know what are the gray line, white line, and the eyelashes like. So if we take a magnified image of the eyelashes or the lid margin, we can see that there is here a lash line followed by a dark area or dark line called the gray line, then followed by a whitish line called the white line, followed by the mucocutaneous junction, which is the junction between the lid and the palpebral conjunctiva. So let's first start with the gray line. So the gray line is an important anatomical landmark because it will divide the lid into lamella. So there will be anterior lamella, which is anterior to this gray line, and posterior lamella, which is posterior to the gray line. Anterior to the gray line will be two layers, which will be the skin and orbicularis oculi muscle. This is the anterior lamella. While posterior to the gray line will be again two layers. This will be the tarsus and the conjunctiva. Both of them will form what's called the posterior lamella. So if we are, this is importance, has a surgical importance in oculoplastics. So if we want to do lid splitting procedure for any reason, then this will be the plane of cleavage of the eyelid between the anterior and posterior lamella. Just posterior to the gray line, there will be white dots. These white dots are the orifices of meibomian glands. The orifices of meibomian glands together makes what is called the white line. The white line is formed by orifices of meibomian glands, and below and posterior to this meibomian glands opening, there will be the mucocutaneous junction. The most anterior line will be the lash line or the eyelashes. The eyelashes or the cilia are numerous hair that arise from the lid margin, and they are present in the upper eyelid and the lower eyelid, but being different in the upper eyelid that they are longer and more numerous. There are two important glands related to the hair follicles or related to the eyelashes that we need to know about because they are very frequently asked in the exam. The first one is the glands of Zeiss. So Zeiss glands are two glands open at the follicle of each cilium. So this is the Zeiss gland. There are two opening at the hair follicle of each cilium or each lashes, and they secrete sebaceous secretion. So they facilitate the emergence of the hair from the hair follicle. There is another glands called the sweat glands of Moll. So sweat glands of Moll are modified sweat glands. And these sweat glands can open either directly on the lid margin or in between the cilia. So they open into the hair follicle as the sebaceous glands of Zeiss, or can sometimes open directly into the skin of eyelid margin in between the cilia. This is also asked in the exam. So remember that Zeiss gland secretes sebaceous and they related directly to the hair follicle, and there are two for each hair follicle. On the other hand, the Moll gland, it is a sweat gland, and they can either open into the hair follicle or can open directly into the skin of the eyelids between the eyelashes. So in the first slide, we said that the structure of the eyelid is complex, although it feels like a very thin and delicate membrane. And this is because it consists of different structures. We have skin, we have muscles, and we have fibrous elements. So there will be skin and the muscles. The muscles of eyelids are mainly the orbicularis oculi and muscles that cause retraction of the eyelid. The orbicularis oculi has four parts: orbital and palpebral, lacrimal part, and the ciliary part. While the eyelid retractors, we have upper lid retractor and lower lid retractors. So for the upper lid retractors, we have the levator palpebrae superioris that we discussed yesterday, and the superior tarsal muscle. While the lower lid retractor are the inferior rectus muscle and again the inferior tarsal muscle. Then we have a fibrous tissue like the orbital septum, like the tarsus, the levator. So let's first start to have a general idea about the anatomy or the structure of the eyelid. From anterior to posterior, the first layer that the lid will consist of is the skin. So the skin here, it is a very thin and very elastic, so it can easily be lifted from the underlying structure by blood or by edema, and it has no fat or visible hair. So this is the skin. So this is the skin, which is the first layer of the eyelid. Under the skin will be the subcutaneous tissue. So the subcutaneous tissue, it is the area just beneath the skin, and it is loose areolar tissue with no fat. Then we will have the muscle. The muscle layer, it will be the palpebral part of the orbicularis oculi muscle. So as it's present into the lid, so it will be the palpebral part of the orbicularis oculi, and attached to the upper border of the torsus, there will be the levator muscle, the levator palpebrae superiosus, which will be attached to the upper border of the torsus. So this is the muscle layer of the lid. And as we have muscle layer, there will be a submuscular area or a submuscular space. The submuscular space, it is this space that contains all the blood vessels and nerves that supply the eyelid. So this layer is very important for surgical consideration, as when we are giving local anesthesia. For example, if we are going to remove a lesion, then we will need to give the patient local anesthesia. And where shall we inject the local anesthesia? This will be at this plane, the level of submuscular space, because this space has the nerve supply of the eyelids. This space, it is represented on the skin by the gray line. So here is the level or the space, here is the gray line, and here is the level that will cause splitting of the eyelid. So this plane divides the lid into anterior lamella, formed of skin and muscle, and posterior lamella, formed of the tarsus and the conjunctiva. Then after the submuscular space, we have the tarsus, and the tarsus, it is a plate, a thin, dense plate, fibrous tissue that will make the skeletal framework of the eyelid. This structure is what will make the lid has its consistency. So without the tarsus, the lid will be rubbery and soft and just a piece of skin and muscle that has no consistency. The tarsus, another importance of the tarsus, apart from the skeletal framework of the eyelid, is that it contains the tarsal glands. The tarsal glands, or what's called the meibomian glands, are modified sebaceous glands that are embedded within the substance of the tarsus and open into the eyelid margin by an opening called the white line, or the orifices of meibomian glands, as we said earlier. Finally, after the tarsal plate, the tarsal plate will be closely or adherent to the palpebral conjunctiva, which will be the last layer, and the lid will be over or finished. So to summarize, we have different layers making up the lid. We have the skin, subcutaneous tissue, muscle, which is the orbicularis oculi, and as you can see here, it is traversed by the levator palpebrae superiosus fascia. So we have the skin, subcutaneous, muscle, and the submuscular space. Then we have the tarsus, and finally we have the conjunctiva. So let's have more illustration about the anatomy of the eyelid. So if you have got the eyelid, so the first layer we will remove will be the skin, and just below the skin will be the subcutaneous tissue or subcutaneous space. Then we will incise the muscle, which will be the orbicularis oculi muscle, the palpebral part of the orbicularis oculi. Then after this, we will reach the orbital fat. So the orbital fat, it is called the preaponeurotic pad of fat. It is just beneath the orbital septum. So if we open the orbital, we'll find just behind the orbital septum will be the preaponeurotic pad of fat. This is in the orbital part, not on the tarsal part. However, if we open the tarsus, if we remove the orbital septum and the preaponeurotic pad of fat, we will find the levator palpebrae superiosus, and attached to the upper border of the torsus. Underneath the levator palpebral superioris will be the molar muscle. So the molar muscle, it is this muscle or the superior tarsal muscle. It is attached, or it is arise from the undersurface of the levator to attach into the superior border of the tarsus. And we can see here, this is the tarsal plate, and beneath the tarsus will be the conjunctiva, as it is adherent to the conjunctiva. The anatomy of the upper eyelid is different from the lower eyelid because we don't have levator in the lower eyelid. So it will be again the same skin and the muscle, and followed by the tarsus. The skin and the muscle and the tarsal plate here, and the tarsal plate is attached by an inferior tarsal muscle which is attached to the lower border, and the capsulopalpebral fascia, which both of them act as lower lid retractor. There will be pre-aponeurotic pad of fat and orbital septum here as well, and arcus marginalis. And this is the orbicularis oculi muscle. So the difference here that we don't have levator, but we have other lower lid retractors such as the lower inferior tarsal muscle and the capsulopalpebral fascia. And here we can see the inferior rectus muscle. So let's discuss the previous structures in more details. Just hold on for a second, please. Hello, sorry, I'm back. Sorry for interruption. So we were just talking about the skin, and we said that the skin of the eyelid is very thin and very delicate, as it is considered the thinnest skin of the body. That's why the blood vessels will appear underneath the skin as blue channels, and this is there will be no fat into the subcutaneous tissue, so it can be easily lifted if there is trauma or there is edema. So it can be easily lifted by blood or by hemorrhage, or by blood or by edematous fluid. And it consists of epidermis, dermis, and hypodermis. So let's have now more details about the orbicularis oculi muscle, which is one of hot topics in the exams and of extreme importance and frequently asked. So what is the orbicularis oculi muscle? This muscle acts like a sphincter of the eyelid. So as you can see, this muscle is arranged into concentric layers around the palpebral fissure, within the eyelid and within the orbit, and covering the orbital aperture. So this muscle is a sphincter of the eyelid, formed by this oval sheet of thin striated concentric layers surrounding the palpebral fissure, that is made mainly from different parts. The outermost part is called the orbital orbicularis oculi, which is related to the orbital margin. Then going more inward, there will be the palpebral part, and the palpebral part is divided into the precipital part of the palpebral orbicularis oculi, which is the part in front of the orbital septum, and the pretarsal palpebral orbicularis oculi, which is the part in front of the tarsus. Then we have a thin strip of muscle that is present into the lid margin, which is called the pars ciliaris, related to hair follicles. And we have a part that will include the lacrimal canaliculi medially at the medial part of the eyelid. This will be called the pars lacrimalis. So again, we have the orbital orbicularis oculi, and we have the palpebral orbicularis oculi. So the palpebral is divided into 4 parts: pretarsal, preceptal, pretarsal, and the pars ciliaris and pars lacrimalis. Let's first start with the orbital part. The orbital part here, as you can see, this is the muscle of the orbital part. It has an origin and insertion and the course and relation like any muscle in the body. So where will be the origin? The origin, it takes origin from the medial margin of the orbit here. And also it takes origin from the anterior surface of the medial palpebral ligament. After this, the muscle run into a circular course concentrically around the globe, and as it runs, it inserts into the superior and inferior orbital margin. So as the muscle run through around the eyeball or around the globe, they will insert into the inferior orbital margin and into the superior orbital margin until they're fused together and attached to what is called the lateral palpebral ligament. So the lateral palpebral ligament is the one of the insertions of the orbital part of the orbicularis oculi. So what are the relations? The orbital part of the orbicularis oculi is spread forward or spread upward to the forehead and spread downward to the cheek and laterally to the temple, and it is covered anteriorly by the skin. So as you remember from the first slides, we said that we have the sections of the lid: skin, subcutaneous, then the muscle. What is the muscle? It is the orbicularis oculi. So the orbicularis oculi will be just beneath the skin, separated by a layer of fat in the orbital part, not in the palpebral part. And there are 2 parts that share or form anterior relations to the muscle. Musculus superciliaris. The musculus superciliaris is the muscle present at the upper end of the medial eyebrow. So it is responsible for depression of the medial end of the eyebrow, leading to this frown appearance. So you know this gesture or this facial expression of frowning, then this is caused by action of the musculus superciliaris. Also, the inferior part, there is a muscle called the musculus malaris. Malaris related to the malar bones, and the lower fibers of the musculus malaris are attached to the cheek. So what is the action of the orbital part of the orbicularis oculi? It is responsible for forcible closure of the eyelid. So if you have, for example, foreign body that entered your eye, or you are frightened by something and you forcibly you closing your eyelid to protect yourself, then this will be the action of orbicularis, the orbital part of orbicularis oculi. Then going more inward inside the eyelid, we will have the palpebral part of the orbicularis oculi. So the palpebral part, it takes origin by superficial heads and deep heads. The superficial heads, it arises from the medial palpebral ligament. So here is the medial palpebral ligament, and here is the attachment of the palpebral part of the orbicularis oculi. So this will be the superficial head. It takes origin from the posterior lacrimal crest. So you can see here, this is the lacrimal fossa, this is the anterior lacrimal crest, and this is the posterior lacrimal crest. and this is the attachment of the deep head of palpebral of the palpebral part of orbicularis oculi. So if we cut the superficial part, you can see here clearly the attachment of the deep heads of the palpebral part of orbicularis oculi. So what happens after the originate by superficial head and deep head? They both fuse together and form a part called the preceptal part in front of the orbital septum, and another part called the pretarsal part in front of the tarsus. So both of them fuse together to form two parts, the preceptal and the pretarsal. Let's see here. So here is the superficial head of the superficial heads, and here is the deep head, like attached to the posterior lacrimal crest, and both of them then will fuse, or both the superficial heads and deep heads will fuse together. They will form what is called the preceptal here, preceptal orbicularis oculi, superior and inferior, and the pretarsal orbicularis oculi, superior and inferior. So here is the superior pretarsal, inferior pretarsal, and this is the superior preceptal, and this is the inferior preceptal. So what will be the insertion? The preceptal part will insert into what is called the lateral palpebral raphe, which is apart from the orbital fascia. As you can see here, this is the preceptal, and this is the medial palpebral ligament, and this is the lateral palpebral raphe. So the the preceptal will run concentrically in a half eclipse fashion until it inserts into the lateral palpebral raphe. While the lateral palpebral ligament, the preceptal, as you can see here, the preceptal orbicularis oculi will insert into the lateral canthal tendon or the lateral palpebral ligament, which will by its turn insert into the lateral witnal ligament or the lateral orbital tubercle. So the preceptal will join to form the lateral palpebral raphe, while the pretarsal will join to insert into the lateral palpebral ligament that will insert into the lateral orbital tubercle. This lateral orbital tubercle and the lateral palpebral ligament are located deep to the medial lateral palpebral raphe. So to remember, just bear in mind that the most anterior structure here is the medial palpebral ligament, while the most anterior structure in laterally will be the lateral horizontal raphe or lateral palpebral raphe, and deep to this lateral palpebral raphe will be the lateral canthal tendon. Here is another section. You can see this is the orbital part, orbital orbicularis oculi, and this is the palpebral part. The palpebral part will have a preceptal portion, and the preceptal meaning that it is in front of the orbital septum. So here is the part of the orbicularis oculi that is in front of the orbital septum. So that's why it's called preceptal. And we have the pretarsal portion, which is the part of orbicularis oculi that is lying in front of the tarsus. That's why it's called the pretarsal. Okay, so this is another section. Let's just see the relations. So anterior to the palpebral part of the orbicularis oculi will be skin and subcutaneous tissue, as we said earlier. And posteriorly will be the submuscular tissue, and the submuscular tissue or the submuscular space will contain the blood vessels and nerves, as we said, and it will be related to the preceptal, as it will be posterior to it, or it will be in front of the orbital septum, and it will be in the preceptal and in front of the tarsus in the pretarsal. So what will be the action of the palpebral part of the orbicularis oculi? It is responsible for the infrequent blinking, or involuntary blinking. So the blinking that you do all your day long, the soft blinking or this smooth blinking action is the function of the palpebral part of the orbicularis oculi. Also for reflexive blinking in response to danger or loud voice. So if you do the reflex blinking, then this this is the precipitatal part of orbicularis oculi muscle in front of the orbital septum, separated from it by fat. And this is the pretarsal part, which is in front of the tarsus, separated from it by the submuscular space. Then we have two small muscles that will form the other parts of the palpebral part of orbicularis oculi. It is called the ciliary part, or pars ciliaris, or sometimes it is named muscle of Raylan. So this muscle of Raylan, it is a very thin strip of muscle here and here, superior muscle of Raylan, and the inferior muscle of Raylan. This is very thin, delicate slice of muscle that is present along the whole thickness of the lid margin. This muscle is traversed by hair follicles and the glands, and its main function is to make the closure of the eyelids tight or watertight, so that if you are closing your eyelids, this will not be spilling over of the tears over the cheek. So this can be done or can be achieved by the tight closure of the ciliary part of orbicularis oculi together by muscle of Raylan. So they will prevent epiphora by tight closure. Finally, we have the lacrimal part, which is the Horner muscle. The Horner muscle will originate from the upper part of the posterior lacrimal crest and the surrounding fascia that enclose the lacrimal sac. Then after this will pass forward and laterally. When it passes forward and laterally, it then will divide into two slips. These slips will enclose the canaliculi and then will become continuous with the pretarsal muscle and Raylan muscle. So this muscle is called Horner muscle or lacrimal muscle. It originates again from the posterior part of lacrimal crest, or posterior lacrimal crest and lacrimal fascia. Then it will pass forward and laterally, dividing into two slips, forming the letter Y that will enclose both lacrimal canaliculi and then become continuous with pretarsal muscle and the muscle of Raylan. So since it is enclosing the canaliculi, what do you expect the function will be? It will be the helps tear drainage. So by contraction of this muscle, it will lead to helping the tear drainage by the action of what's called lacrimal pump. So what is the lacrimal pump? It is the contraction of and relaxation of the lid muscle that is responsible for tear extraction from the palpebral fissure and the drainage of the tears through the puncti, canaliculi, and lacrimal sac. And how is this possible? So for the first instance, when we are closing the eyelid, we are causing contraction of the muscle. So the muscle of Horner will contract, leading to creation of negative pressure into the lacrimal sac. This negative pressure will suck the tear film from the palpebral fissure into the lacrimal sac. Then when we open the eyelids, this will lead to relaxation of the muscles. Relaxation of the muscle will cause the positive pressure into the lacrimal sac that will push down the tear film or the tears into the nasolacrimal duct and cause closure of the puncti. So this is called the lacrimal pump mechanism. By contraction and relaxation of the palpebral part of the orbicularis oculi, specifically the muscle of Horner, this will lead to suction of the tears from the puncti to the canaliculi and the positive pressure that will push these tears into the nasolacrimal duct. Then after we know what are the parts and relations of different parts of the orbicularis oculi, here we come to the nerve supply. So the orbicularis oculi, it is supplied by the facial nerve. So as we know that the facial nerve is enter the parotid gland, and then it emerges from the parotid gland with its terminal branches. So we have 5 terminal branches of the facial nerve: the temporal, the zygomatic, the buccal, the mandibular, These branches, only the upper two branches, which is the temporal and zygomatic, are responsible for supplying of the orbicularis oculi. So the upper part is supplied by the temporal branches and the upper zygomatic branches, while the lower part of orbicularis oculi, it is supplied by the lower branches of lower zygomatic branches. That's why if the patient has a facial palsy, they will have what is called the lagophthalmos, or exposure of the eyeball from inability to close the eyelids. So is everything clear up till now? Do you have any questions? For the lower motor neuron, it will be on the contralateral side. So let's just postpone this. The facial nerve will be discussed in the next lecture of the neuroanatomy, and we will discuss in details what will be the nerve supply of the facial nerve and what are the effect of any lesion of the facial nerve. So we'll discuss what's upper motor neuron and lower motor neuron fascia. Okay, so let's now we finished the muscles of the eyelids. And let's now discuss the fibrous tissue of the eyelids. We have mentioned the capsulopalpebral ligament yesterday, and we said this ligament will attach the inferior tarsus to the ligament of Lockwood, or suspensory ligament of the globe. This attachment is one of the main retractors of the lower eyelid, and it is analog to the levator muscle into the upper eyelid. So we don't have levator into the lower eyelid, but the corresponding retractor of the lower eyelid will be the capsulopalpebral ligament, which will be attached to the inferior part of the inferior tarsus, the Lockwood ligament, and has also attachment to the inferior rectus and the inferior oblique and the tenon capsule. Here you can see the capsulopalpebral fascia attaching the inferior border of the tarsus to the Lockwood ligament. And since it is attached to the tarsus, this will make it the main retractor of the lower eyelid. So what are other lid retractors? The eyelid retractors are simply some smooth muscles that are attached to the upper border of the upper tarsus and lower border of the lower tarsus. So by their contraction, they will lead to retraction of the eyelids. In the upper tarsus, it is called the molar muscle or the superior tarsal muscle, while into the lower eyelid, it is called the inferior tarsal muscle. Both of these muscles are sympathetically innervated. That's why people who have a sympathetic overstimulation, like patients with thyroid eye disease, they will have lid retraction. This is because due to overstimulation of the molar muscle and lower lid retractors. The upper tarsal muscle or the superior tarsal muscle, as we mentioned earlier, this muscle originates from the undersurface of the levator palpebrae superiosus muscle and attached to the superior border of the upper tarsus. While the inferior tarsal muscle, it originates from the inferior rectus sheath and insert into the lower border of the inferior tarsus. Both of these lower lid retractors and the capsulopalpebral ligament act as a retractor for the lower eyelid. So the retractor for the lower eyelid are the capsulopalpebral ligament and the inferior tarsal muscle. So here is the section of the globe. Here is the superior tarsal muscle, and here is the inferior tarsal muscle. As you can see, they are both attached to the upper border of the upper tarsus and lower border of the lower tarsal contraction. This will lead to a retraction of both eyelids. Then we have an important barrier that is closing the orbital opening and present into the eyelids. It is called the orbital septum. So the orbital septum, it is a fibrous sheet that form the fibrous layer of the eyelid. So all this whitish area, it is called the orbital septum. The orbital septum importance that it acts as an anatomical barrier. So it is present here and here, making a separation between the orbital fat, as you can see here, and the skin of the eyelids. So once this barrier is breached or it is opened, for example, like senility, you can see that there will be redundancy of the fat, or the fat pockets herniate into the eyelids, causing this boogie appearance of the eyelids. So this is due to senility and weakness of the orbital septum. So the orbital fat become now enter into the subcutaneous area. Also, as it prevent entering of the fat from the orbit into the eyelids, it prevents spread of infection from the eyelid into the orbit. For example, in case of orbital cellulitis. So the orbital cellulitis, meaning that the infection is spread from the eyelid, or sometimes it complicates the preseptal cellulitis. So the infection spread from the eyelid into the orbit through the orbital septum. So this is the main function of the eye, the orbital septum, that it acts as a barrier. Also, it has a function in the sharing in the movement of the eyelids. So, what is the thickness? The thickness of the thickness of the orbital septum, it is more in the upper eyelid and it is more medially. What about the relations? So centrally, the orbital septum is attached to the levator palpebral superioris muscle aponeurosis. So centrally, it is fused with the levator aponeurosis, and it is in the upper eyelid, while in the lower lid, it is attached to the lower border of the tarsus, like here. Peripherally, it is attached to the upper and lower border of the tarsus, and laterally, it is attached to the lateral palpebral ligament, which is attached to the Whitnell ligament or lateral orbital tubercle, as we said yesterday. And medially, it reflects posteriorly, so it is not anterior. So I want you to remember this relation is very important. So the medial part of the orbital septum, it is reflected posteriorly to the posterior lacrimal crest. So the lacrimal sac will be situated in front of the orbital septum, and the medial palpebral ligament, it is situated in front of the lacrimal sac. Attachment of the orbital septum. So the orbital septum has a unique attachment into the orbital margin. It starts by the Whitnell tubercle. So then it will cross the what's called the frontozygomatic suture and run then at the posterior lip of the superior orbital margin. Then it crosses the supraorbital notch. Then it will descend to reach the upper part of the posterior lacrimal crest. As you can see, this is the lacrimal fossa, this is the posterior lacrimal crest, and this is the anterior lacrimal crest. As it ascends, descend at the upper border of the posterior lacrimal crest, then it will cross the middle of lacrimal sac. After this, it will reach what's called the lacrimal tubercle, which is the lower part of the anterior lacrimal crest. Then it passes into the inferior orbital margin and the zygomatic arch. Then it will leave the orbital margin for a specific area called the premarginal recess of Eisler. So the premarginal recess of Eisler, it is present at the zygomatic bone. It is just an extension of the attachment of the orbital septum away from the orbital margin. After this, it returns again to the lateral orbital margin and it will reach the Whitnell tubercle again. So here is the attachment of the orbital septum. It starts by the lateral orbital tubercle, cross the frontozygomatic suture, then pass onto the posterior lip of the superior orbital margin, cross the superior orbital foramen. Then it will descend into the medial wall. Then it will reflect posteriorly to the posterior lacrimal crest. then it will cross the lacrimal sac to insert into the lacrimal tubercle, which is the lower part of the anterior lacrimal crest. Then it will descend into the inferior orbital margin and the zygomatic bone, and at the zygomatic bone it leaves the zygomatic bone or leaves the inferior orbital margin for a limited area or limited space called the premarginal recess of Eisler. Then it will return again to insert into the Whitnall tubercle. The relations of the orbital septum, it is anterior to the orbital septum will be the orbicularis oculi, as we said before, and as we saw in the video. So this is the orbicularis oculi, and if you just strip it, you will find the orbital septum. Posterior to the orbital septum will be the orbital fat. So the orbital fat will separate the orbital septum from lacrimal gland and from the levator muscle in the upper eyelid. While so if the levator muscle, it is identified by presence of the pre-aponeurotic pad of fat. In the lower eyelid, the fat will escape from orifices of expansion of inferior rectus and inferior oblique. One of the most very important topics or very important areas of questions are the structures that pierce the orbital septum. What are the structures that pierce the orbital septum? First, we have three sets of nerves and vessels. So we have lacrimal, supraorbital, supratrochlear, artery, nerve, and vein. Again, lacrimal, supraorbital, supratrochlear, nerve, and artery, and vein. Also, we have a specific nerve, specific artery, specific vein. What are these? It will be the infratrochlear nerve, the dorsal nasal artery, and the anastomosis between the superior ophthalmic vein and the angular vein. Then we have two arteries and two muscles. Two arteries are the superior and inferior palpebral arteries, and levator palpebral superiosus in the upper eyelid, and the prolongation of inferior rectus into the lower eyelid. So here we can see what are the three sets. We have the the lacrimal nerve and artery and vein. It will perforate the orbital septum laterally. We have the supraorbital vessels, supraorbital artery, vein, and nerve, and we have the supratrochlear artery, vein, and nerves. Then we have specific artery and specific vein and specific nerve. What are these? Specific artery is the dorsal nasal artery. Specific vein, it is the anastomosis between the superior ophthalmic and the angular vein, will perforate the orbital septum, and the specific nerve will be the infratrochlear nerve. Then we have two arteries, which are the superior and the inferior palpebral arteries, which will give rise to the medial and lateral palpebral arteries. And finally, we have two muscles, which is the levator palpebral superiosus and the prolongation of inferior rectus. Other fascial components or other fibrous components of the orbit are the medial and lateral palpebral ligaments. So let's start with the medial palpebral ligament. Sometimes it is called the lateral canthal tendon. And this tendon will attach the upper tarsus and the lower tarsus to the medial orbital margin. So it is a triangular band of fibrous tissue that will attach the upper and lower tarsus to the medial orbital margin. It's about 9 millimeters in length, as you can see here. This is the upper crust and lower crust of the medial palpebral ligament. It is Y-shaped, attaching the medial orbital margin to the upper and lower tarsus. So what will be the attachment? As you can see here, this is the medially, or the medial attachment will be called the attachment of the medial orbital, the medial palpebral ligament will be between the anterior lacrimal crest here and the nasomaxillary suture here. So this will be the medial attachment of the medial palpebral ligament. Again, it will be between the nasomaxillary suture and the lacrimal crest. The posterior attachment is from the anterior from this medial attachment. Then the medial palpebral ligament will be divided at the anterior lacrimal crest here into two parts that will take one part. It will be reflected here to form or to be continuous with the lacrimal fascia and the posterior lacrimal crest. So again, this is the posterior reflection of the medial palpebral ligament, and the anterior part will continue as a Y-shaped band that will be attached to the tarsi. So let's again discuss the anatomy or the attachment of the medial palpebral ligament. It has a medial attachment that is a rise between the nasomaxillary suture and the anterior lacrimal crest. After it arises and it reaches the anterior lacrimal crest, it will give posterior attachment or posterior part that was reflected to cover the lacrimal sac, forming the or sharing in the formation of lacrimal fascia, and attached to the posterior lacrimal crest. While the anterior part, which is forming the main bulk of the medial palpebral ligament, it will be running forward and laterally to attach to the superior tarsus and inferior tarsus. Here you can see this is the medial palpebral ligament and its attachment to the upper tarsus and lower tarsus. So what are the relations of the medial palpebral ligament? The upper border is continuous with the periosteum and the lacrimal fascia. So here, this is the medial palpebral ligament, and this bluish structure, it is the lacrimal sac. As you can see, it is located behind the medial palpebral ligament. So the upper border of the medial palpebral ligament will be continuous closing the lacrimal sac, while the lower border of the medial palpebral ligament, the fibers of the orbicularis oculi will pass behind it. So we said that the medial palpebral ligament will give origin to the orbital part of orbicularis oculi. So the medial palpebral ligament is situated in front of the orbicularis oculi muscle. Anterior to the medial palpebral ligament will be the angular artery and the angular vein here. And the posterior surface of the lacrimal sac will be the orbital septum, as we just mentioned, and the lacrimal sac and its fascia. So the lacrimal sac here will be behind the orbital septum, will be behind the medial palpebral ligament, and behind the lacrimal sac will be the orbital septum. The importance or the applied anatomy of the medial palpebral ligament, that if you want to feel your medial palpebral ligament, you can just push your eyebrow superior and lateral in this direction. You will find that there are two bands, two string-like bands in the upper and lower lid margins. You can feel them now. These are the medial palpebral ligament. And if in case of that there is a lacrimal sac swelling, it is usually located inferior, or it usually will be below the medial palpebral ligament. So lacrimal sac swelling, such as acute dacryocystitis here, is usually present below the medial palpebral ligament. And if we are doing a DCR or dacryocysto-rhinostomy surgery, then we need to have good exposure of the lacrimal sac. So in order to have a good exposure of lacrimal sac, we need to cut the medial palpebral ligament, because as we said, or as we can see from the previous slide, it is crossing over the lacrimal sac. Okay, so now we will discuss the lateral palpebral ligament. So the lateral palpebral ligament, it is a tissue of orbital septum behind the lateral palpebral raphe. So we said that the lateral palpebral raphe is the most anterior, and behind it will be the lateral palpebral ligament. The size of lateral palpebral ligament will be 7 per 2 millimeters, and it is attached medially to the tarsus, as you can see here, and laterally to the Whitnell tubercle. So it is the lateral canthal tendon or the lateral palpebral ligament. Again, it is one of the attachments of the Whitnell ligament. So what are the relations of the lateral palpebral ligament or the lateral canthal tendon. So the upper border of the lateral canthal tendon will be continuous with the levator aponeurosis, and the inferior part or the inferior lower border of the palpebral lateral palpebral ligament will be continuous with the inferior rectus and inferior oblique expansions. Anterior surface to the lateral palpebral ligament will be the muscle of Raylan, some lacrimal gland lobules, and lateral palpebral raphe and orbital septum. While posterior surface of the lateral palpebral ligament will be the lacrimal glands again and lateral cheek ligament. Another important structure or fibrous structure of the lid, which is the tarsus or the tarsal plate. So we have two tarsal plates, upper one and lower one. Both of them make the skeletal framework of the eyelid, and they are the upper tarsus is more large, so its length is about 25 to 30 millimeter, while this is the length of both of them. However, the height of the upper tarsus, it is more than the lower tarsus. It's more than double. So the upper tarsus is tall or show greater length than or greater height than the lower tarsus. It extends from the lacrimal puncti medially to the lateral canthus. So the medial puncti here are located here, and the tarsus include from the or extend from this medial canthus to until the lateral palpebral ligament and the lateral canthus. So I just brought this slide to see this is the recess of Eisler. You remember when I told you about the attachment of the orbital septum, and it leaves the inferior orbital margin at the area of the zygomatic bone. This is to form the recess of Eisler, and this is the premarginal recess of Eisler. So what are the relations? What is in front of the tarsus? So in front of the tarsus will be the skin and the muscle. So as we said, there will be skin, subcutaneous, muscle, submuscular space. These all are in front of the tarsus. On the other hand, the posterior surface of the tarsus will be in close adherence to the conjunctiva. So both of them are closely adherent together. As you can see here as well, in the inferior tarsus, in front of the inferior tarsus will be the skin and orbicularis oculi muscle, and behind will be the conjunctiva. So here the levator aponeurosis or the levator palpebrae superiosis, it is attached to the anterior surface of the tarsus, and as we said yesterday, this is one of the 5 attachments of the levator palpebrae superiosis to in the eye. It will be the anterior surface of the tarsus. So what are the relations? It is in the inferior or the free margin is thick and form the lid margin, while the attached margin, it merge into the orbital septum and attached to the molar muscle. So here in the upper tarsus, you can see that the upper border, it is attached to the tarsal muscle or the superior tarsal muscle. And the inferior one will be attached to the inferior tarsal muscle. Medially and laterally, it will be both hanged together by the medial and lateral palpebral ligament, which will attach them to the medial and lateral orbital wall. Then we will come to an important topic in the eyelid, and also it is asked frequently, which is the glands of the eyelid. So we have 3 main glands. We discussed 2 of them already, which is the Zeiss gland and the Moll's gland, but we need to have more information about the meibomian gland. So the meibomian glands are modified sebaceous glands. They are not related to hair follicles, and this is always asked in the MCQ. So as you can see here, this is the meibomian glands embedded in the tarsus, and this is the eyelashes. So you can see that the Zeiss gland is related to the hair follicle. However, the meibomian gland is away from the hair follicle. The meibomian gland or the tarsal gland are arranged into a single row within the substance of the tarsus, and they run from the attached border to the free border until they open into the eyelid margin by an opening called the white line. and this white line, it is just behind the gray line as we said earlier. So you remember when we said that this is the gray line and this is the white line, and the white line, it is formed by the orifices of meibomian glands. So here you can see this is the site of gray line, just anterior to the meibomian gland, or this is the tarsal gland or meibomian gland, opening into the lid margin by the white line, which is just posterior to the gray line. The number of the meibomian glands are more numerous in the upper lid than the lower lid. So in the upper lid, they are making up to 25, while in the lower lid, they are making up to 20 glands. You can be able to identify these glands clinically. So the wide opening of the orifice of meibomian glands can be sometimes be evident clinically, especially if meibomian glands are inflamed or show dysfunction. They will show like yellow dots or yellow drops over or capping over the orifice of meibomian gland. And if you avert the eyelid, you will be able to see some vertical yellowish streaks in the palpebral conjunctiva. These are just the meibomian glands embedded into the substance of tarsus. The structure of the meibomian glands are 10 to 15 globular acini. So these are the acini, and they are arranged around the central canal that will open into the lid margin. So here are the acini, and arranged around the central canal that will open into the lid margin. So what is the function of the sebaceous glands or the meibomian gland? So the meibomian gland is secreting oily secretion or sebaceous secretion that will form the external layer of the tear film. So if we have this is the epithelium of the cornea, we will know in the physiology that the tear film, it is not a single layer, but it is 3 layers. The first layer, which is attached to the epithelium, it is called the mucinous layer. Then most of the tear film thickness formed by the aqueous layer, and finally the outermost layer will be the oily layer. This oily layer is made mainly by the sebaceous glands present in the tarsus, and this oily layer will help to prevent the rapid evaporization of tears. So what happens if there is meibomian gland dysfunction? Just hold on for a second, please. Okay, so this is if there is meibomian gland dysfunction, this will lead to rapid evaporization of tears, and this will lead to will share in the pathogenesis of the dry eye. Glands of Moll. The next gland or the second type of glands is called gland of Moll, and these are modified sweat glands. They are present in the hair follicle, can be present in they are open into the hair follicle or directly into the skin between the eyelashes, and so this is one important thing that is asked in the MCQ. It can open in between the eyelashes or into the hair follicle. But the most important that is asked in the MCQ is its number, because apart from all the structures that we have mentioned, the Moll gland are the only structure that is more numerous in the lower lid than the upper eyelid. So we said that the upper lid is more in height and has more sebaceous glands and more eyelashes, but it has less glands of Moll. So gland of Moll, it is more in the lower lid than the upper eyelid. They are formed unbranched or formed by spiral tubules, formed by secretory portion and ducts. And finally, we have the glands of Zeiss, which is again a modified sebaceous gland. So they produce sebaceous secretions like that of meibomian glands, but they are related to hair follicle. So we have 2 glands of Zeiss in relation to each hair follicle that open directly into the hair follicle. The glands of Zeiss are cubical cells, sometimes showing polyhedral cells resting on basement membrane, and its function again is to secrete oily secretion that form the external layer of the tear film. Is everything clear up till now? Okay. Now we'll come to an important topic of the eyelid, or important subtopic of the eyelid, which is the vascular supply of the eyelid. How can or how does the eyelid receive its blood supply? The eyelids are receiving their blood supply from arteries named by the eyelid, so they are called medial and lateral palpebral arteries. These medial and lateral palpebral arteries are arteries that its main function is to supply the eyelids. The medial palpebral artery is one of the branches of the ophthalmic artery, as we will say today. And then after it emerges from the ophthalmic artery, it give superior and inferior branches. The superior branch will supply the upper eyelid, while the inferior branch will supply the lower eyelid. On the other hand, the lateral palpebral artery is a branch from the lacrimal artery, and again it will give superior and inferior palpebral artery. So it will give superior and inferior branches from the lateral palpebral artery. The superior branch of lateral palpebral artery and superior branches of the medial palpebral artery will join together to form what's called arcades. So in the upper eyelid, there will be two arcades. The first one at the tarsus, or in front of the tarsus, it is called the tarsal arcade. And we have a peripheral one above the upper border of the tarsus. It is called the peripheral arcade. On the other hand, the inferior branches of lateral palpebral arteries and inferior branches of the medial palpebral artery will join together to form arcade into the lower eyelid, which is a tarsal arcade only. So we don't have a peripheral arcade into the lower eyelid. So we have marginal arcades or tarsal arcades in both eyelids, but we have only peripheral arterial arcade into the upper eyelid. These arcades are present, or the tarsal arcades are present in close relation to the lid margin. In which level? It is in the submuscular area. As we said, the submuscular area, it is the level of the presence of all blood vessels and nerves that supply the eyelid. Also, the medial and the lateral palpebral arteries will receive some branches from the external carotid artery, such as the superficial temporal, transverse facial, and infraorbital arteries. So all of these arteries will share in the formation of the marginal arcades. Here you can see this is the inferior arterial arcade or marginal arcade that is present into the level of submuscular area. So this is one of the questions in the exam. Where is the arcade is located? It is located into the submuscular area. As we said, the peripheral arterial arch or the peripheral arterial arcade here, it is present in the upper eyelid only, and it is made by the superior branch of the medial palpebral present in the upper border of the tarsal plate. So what is the function of these arcades? Either the two marginal arcades and the one or the single peripheral arterial arcade in the upper eyelid. Their function is to supply the eyelids. So how can they do so? This can be done by perforating branches that perforate anteriorly to supply the orbicularis oculi and the skin, and perforate posteriorly to supply the tarsal gland or the posterior lamella in the form of tarsus and the conjunctiva. And this will be discussed in more details later on. The venous blood supply to the eyelids is more large and more numerous than the arteries, and again they are arranged into the pretarsal and the post-tarsal plexus. The pretarsal plexus is draining the anterior lamella, so draining the skin and the orbicularis oculi by the facial vein. So here is the facial vein, and the drainage of the anterior lamella of the skin and orbicularis oculi is coming from the facial vein, while the posterior lamella, which is the tarsus and the conjunctiva, it is drained by the ophthalmic veins, the superior ophthalmic vein and inferior ophthalmic vein. The lymphatic supply of the eyelids will follow the course of the veins. So they are again will form a pretarsal plexus and the post-tarsal plexus. So from the pretarsal plexus will drain the anterior lamella, the skin and orbicularis oculi, while the posterior or post-tarsal plexus will drain the posterior lamella, which is the tarsus and the conjunctiva. The lymphatics from both groups will be arranged according to medial or lateral. So the lateral part of the upper and lower eyelids will either from the pretarsal or and the post-tarsal plexus will join together to drain into the preauricular lymph nodes and the parotid lymph nodes, while the medial part of the upper eyelid and the lower eyelid will drain into the submandibular lymph nodes. Both of the preauricular lymph nodes and the submandibular lymph node will drain into the upper deep cervical lymph nodes. So the nerve supply, finally the nerve supply of the eyelid, can be either motor or sensory. The motor nerve supply of the eye will be toward the orbicularis oculi by the facial nerve, as we said earlier. The levator palpebrae superiosus will be supplied by the superior division of oculomotor nerve, and the molar muscle, which is sympathetically innervated. Either the molar and the inferior tarsal muscle will be sympathetically innervated. The sensory supply of the eyelid can be divided into 3 parts. So every lid can be divided into the medial part, middle part, and lateral part, either in the upper lid and the lower lid. So the medial part of the upper eyelid, it is supplied by the supratrochlear nerve, while the medial part of the lower eyelid is supplied by the infratrochlear nerve. The middle part of the upper eyelid will supply by supraorbital nerve, while the middle part of the lower eyelid it is supplied by the infratrochlear nerve. Both lateral part of the upper eyelid and the lateral part of the lower eyelids are supplied by the lacrimal nerve. And this is again the same nerve supply of the conjunctiva. So we will divide the lid into 3 parts, and each part will be supplied by a specific nerve. So this will be the end of the